fascinating aspects in our lifetimes as well has been the changes in chemotherapy. I mean, it's not many people know that 5-FU was first used in 1957, and it's quite fascinating. If you look at this slide, Merv, it's still included in a lot of those. Could you tell us what's happened in chemotherapy?
It's very interesting, Brendan, because up until the turn of the millennium, really we used to regard chemotherapy and the liver as just a joke, really. It didn't really do very much. And then after the millennium, oxaliplatin and FOLFIRI, which is irinotecan, 5-FU came in. 2004 we started getting cetuximab and so on. And as you can see, we started getting a big influence on the size of liver secondaries. But to their huge disappointment is that when we randomized them to surgery or not surgery, actually whether they had chemotherapy or not didn't actually improve the 5-year survival. Now, you could read that as a negative, but actually what is important for people to realize is, as I showed earlier, we are now operating on far more cases than we ever did. And that's because chemotherapy has reduced the size of the secondaries to allow us to operate. I think even the most ardent oncologists would now agree that the chemotherapy on its own is not enough, because these cells mutate, they are clever. So when you get that opportunity to take them out, you've got to take them out, because otherwise they'll regrow. So the first EPOCH trial we did, I remember there was a planning meeting in Manchester, and they said, oh no, it's chemotherapy, it's very safe, you can give it as long as you like. And then when we looked at it, if you had more than 6 months chemotherapy, there was life-threatening complications, which originally had a p-value on it.
This is before liver surgery.
Yes,
yeah.
As a sort of neoadjuvant chemotherapy, much higher surgical complications and mortality. And we said, hang on a minute, if you're going to do a trial, can we just limit it to 3 months neoadjuvant before the liver? Because otherwise it makes our world too difficult. And the second thing we showed was that they said, oh, we can stop chemotherapy, just carry on. And we, in the same paper, we published this that showed that actually, if you wait more, if you wait 6 weeks, then you far less complications. The liver, the immunity is improved, the patients are fitter. And we all know that, prehabilitation is now a big part of getting good results out of surgery. So our papers, on these topics were really important. But, I show this case because she's a young girl who in 2006 came to, they sent me the scan from Bedford, and I wrote back and said, this will never become operable, to my shame, because I think that writing people off should never be part of our treatment option. But yeah, I think you'll agree, that's a pretty spectacular tumour. Yeah. And she had 3 months of FOLFOX, and then they added in cetuximab, and I'm going, crikey, I can't believe that. So send her down. She came down and she had this horrible rash from the cetuximab. And anyway, we did her, and that's the operative photograph. Okay, we took a little chunk out of the vena cava there, you see, and the margin is pretty tight. We wrote it up as cetuximab, a new team player. It was the first, I think she was the first patient in the UK to have this new wonder drug. And anyway, she's still alive 15 years later. She had a lung met along the way. This is an absolutely groundbreaking moment in the evolution of all this work. And which brings me to a topic that, if you remember, one of the original selection, they said you've got to have a centimetre. Well, and the Americans were pushing this forward not that long ago. So we did this paper combined with Leeds, who had a very similar attitude to us. And we put together, I think, 2,700 patients. And it showed that basically a millimetre is absolutely fine. And even if it's just capsule, it's not that bad. And I seem to remember a close shave, a paper of yours, Bill, in the lower rectum. So that's what drove me, you see, because I knew of your paper. I'm going, well, if a millimetre is good enough for you in the rectum, why can't it be good enough in the liver? And actually we show that it is good enough.
And of course, you also have the effect of the CUSA and the diathermy and so on.
And the CUSA takes a little bit more. So, you know, when we say, look, it may look positive margin, but we've taken extra with the CUSA just to be on the safe side. And I think, so one of the things that has always bothered our colorectal colleagues, I'm sure you're included, Brendan, is when we say we'd like to do the liver first, please. When this first came up, I remember there was quite a few people quite vocal against this, because of course traditionally, inoperable patient of chemotherapy, you do the primary, and then we would do the liver. And this sort of case, inoperable, I think you can see pretty well every vessel is involved.
Right in the centre of the liver.
Right in the centre, that great big black thing. And then you start going, well, you know what? That vena cava is probably clear. The porta's just clearing up. And then you can see the vena cava skeletonized, the right vein and the right porta. So, you know, that's the sort of stuff that we can do. That's what we call a liver first, because if there's any delay, then they would regrow and then you can't do it. And what's really irritating me for years is we had done this for years before Gilles Menther, the late Gilles Menther, published just 20 cases or so in the British Journal of Surgery, because it just seemed an obvious thing to do to me. But anyway, they published it. But if you don't publish, you don't get your name attached to the procedure. But we did do the biggest single centre study, which Fenella Welsh wrote up, looking at who were the patients that were liver first and what happened to them. And as you can see, just to reassure our colorectal colleagues, liver first out of over 1,000 patients is only 17%. So the commonest sequence is still bowel and then liver. And of course, we've only done a few simultaneous, and we can talk about that if you wish later. But so most people had the classical approach. But when we did the liver first, usually that they were inoperable or borderline operable, and they have neoadjuvant chemotherapy, and we just grab that opportunity. A few cases who have radiotherapy to the rectum, control the primary, and while you're waiting for all that to settle down, we just nip in and take out the liver. So those are the indications. Perhaps don't need to dwell on this, but just to show that the groups were similar in terms of big operations, particularly in the liver first. A lot more nodules that are bigger in size, and the overall survival was still the same. And when we matched it for our predictive index, it was identical. So it doesn't do any harm to go liver first, as long as you get on with the primary soon afterwards.
I think that's a really important point, because we as colorectal surgeons used to want to get the primary out at all costs. But actually we know if it's got metastatic disease, or likely, then systemic chemotherapy up front and then staged approach is really good. So I think, and I've been involved in a number of these cases with you, Merv, you do the liver and then I have to do the bowel. And of course the patients are very disappointed because they recover very well from the liver operation, and then we take out the rectum or something and they're very unwell. But it's and Merv is right, if we create chaos with a bowel operation, they'll never get the liver resection.
So, but you wouldn't want to do the liver first if you don't need to give chemotherapy, for example.
Exactly.
You know.
Well, very often patients who have liver secondaries have also got an advanced primary, and not always, but they often have. And I think now we know with Rapido that probably short course radiotherapy is better than long course for the primary. It seems to me that there must be a steady reversal of that percentage, and that we will be giving short course radiotherapy to a primary that deserves it on its own, perhaps through the mesorectal fascia or whatever, and you will be doing the radiotherapy and the chemo. Unfortunately, there's a little difficulty in defining how much chemo is necessary for the liver, but it seems to me you should give liver dose chemo plus short course radiotherapy to the primary. Then you will have overcooked the primary chemo wise, and you go first. It seems to me you should be going first more.
Well, equally though, we need the assurance from a colorectal surgeon that they are happy that the rectum is operable.
Yeah.
You know, I think that it would be a disservice to that patient if we cleared the liver and then they die of pelvic local disease.
It's almost bad to die of local pelvic disease.
So we do need that assurance.
We've had an occasional one, Merv, I can recall that sometimes, cancer is sometimes unpredictable, isn't it? No matter what you do, every now and again, but we've seen more and more of the liver first, and actually if you control with systemic chemotherapy, do the liver metastasis, and then the bowel surgery is actually in many ways easier, and you know everything is under control. But they do. It is a big hit for these patients. Our recent patient from Wales, you did his liver resection. He was absolutely fine. I took out his rectal cancer, and it did knock the stuffing out. Of course, he's had chemotherapy, liver resection, and then
it's always worse if you're the third along.
Yeah.
So why we want to be? That's why we want to come second now. I'm fed up of being the third along. Yeah. So I mean, just as an aside, chemotherapy has, of course, done fantastic things, but it's at a price. Because it does cause damage to the liver, and we've talked there about 5FU and high BMI causing steatosis, oxaliplatin with this sinusoidal obstruction syndrome, or, you know, the liver does look blue, which is really an extraordinary phenomenon, and irinotecan, steatohepatitis. And the thing about this is that actually it's not predictable. We know that it causes increased morbidity and even mortality from various studies. But one of the things that we did, our own study, showed that you have one patient who has 6 months chemotherapy and the liver doesn't turn a hair. Another one, you give 3 months chemotherapy and they have terrible trouble afterwards. So this is the latest study that we did with Perspectum, which is a translational company in Oxford, and the University of Edinburgh, where we use this technique called multiscan, and which allows us to see through an MRI technique, and I can't tell you how it works because they won't allow us to know, because obviously trade secret and all that. But for a surgeon, it's very simple. If we now know that we were blinded in the study that we did with Edinburgh, but if the liver is green, that liver's healthy.
Good Irish liver.
Yeah. If it's yellow, you've got to be careful. If it's red, you've got to be very aware, and almost certainly not take out half a liver.
And is this showing you liver function? Is it? I mean,
it's the well-being of the liver. It's a sort of the level of inflammation, steatosis, steatohepatitis, inflammation, fibrosis, and so on. So, for example, when we look retrospectively, so there's one of the patients in the study where I needed to do an extended right apopectomy, and I was sort of worrying 2 nights beforehand. God, you know, the liver remnant, I think it was about 20% or something. Here's the patient, yeah. So liver remnant of 30%. Is that going to be okay? She'd had a bit of chemo. What I didn't know was that the liver was green, and this patient never turned a hair, went home on day 4. And if I'd known now, and what we're now doing is doing it up front.
So how do they actually do it? Presumably it's some algorithm, which is the big thing in medicine, isn't it?
It's an MRI technique.
An MRI algorithm based on some sort of contrast agent.
No contrast.
No,
I can't
so
tell you.
it's an artificial intelligence type approach, is it, where the MRI is calculating the...
Well, it feels like that because they won't tell me how they do it. So, and then in contrast, there's this patient who, on paper, had 3 months of chemotherapy, similar or lesser operation, at least as much liver left behind. You know, we did the liver resection and his bilirubin went over 100, and I'm losing sleep afterwards thinking, oh my God, I hope this is going to stop. But of course, if I'd seen that picture, I'd have realized that we needed to do a right portal vein embolization to cause the left side to hypertrophy before doing the operation, and he would have been home on day 4. So we're now doing another study combining it with the genomics to see is our selection correct. That's work in progress at the moment. And look at this patient, you see. His liver's pretty red, okay?
Yeah.
And he was down to do a right hepatectomy, and he's part of the study as well. And I'm going, God, I wish I knew what this, because when I opened him up, I thought, oh, I'm not sure about this liver. So I actually did a very difficult posterior section, segment 6-7, up along the cava, which was really difficult because the right hepatectomy was the easy op. And as it is, he was fine, but if I had done a right hepatectomy, he would probably died.
So it's the functional remnant. You had the remnant has to. Before we just, it's very fascinating is the liver regeneration. But tell me, why does the liver regenerate?
Oh, that's $1 million question, Brendan. The people have spent millions on.
Why does it do that?
We don't know. I mean, there's the stimulus of you divert the blood from going 2 ways down 1 way. So
you talked about portal vein embolization. Just explain what that is to us.
So you percutaneously put a needle into the right portal vein and embolize it. People have their own ways, but you need to block off the whole of the right portal vein, and then
the liver on the left grows.
The blood is diverted to the left side, so part of it is congestion. We know that, but that stimulates all sorts of a reaction, inflammatory reaction, whatever, and we don't fully know the exact mechanism or what even turns it off. Why does it
keep growing?
Why doesn't it keep growing? Exactly. But what we also know is that any small tumor in that remnant liver will also grow. So, you know, we have to be very careful. And actually what is interesting is that we talked earlier about the ALPS procedure, which has got a formidable sort of reputation with a high mortality. That we now know that pre any surgery, the results from a right portal vein embolization combined with embolization of the right hepatic vein gives you the same dramatic hypertrophy of the left lobe as you do with what we call an ALPS procedure, where you go in and do most of the transection and divide the right portal vein, and the stimulus of transecting most of the parenchyma causes this massive hypertrophy, but you can do it radiologically as long as you do the portal vein first. Because if you do the hepatic vein first, of course, it's not very good thing.
I mean, one of the things, Bill, that you've said, and I think is true, is that so much information on MRI scans, and we've been saying that there's so much information that we don't use on rectal cancer MRI scans.
I'm guessing that this comes from radiomics, which is really looking at all the rest and getting functional information that is there and hasn't been tapped previously.
I think it is, Merv. It's fascinating. It's with the beautiful colour pictures it can produce.
I know. But this is where we want to get to, so that
we should buy shares, Merv.
Yeah, we send the scans in, and they would ideally send us this kind of report saying, right, if you do that operation, you're going to be left with a 35% future liver remnant. But because of the quality of the liver, it's the equivalent of 20%.
Okay, so they can make a calculation.
So they'll calculate and tell you, you know what, all we can do is tell you the information. But that information would tell me, oh okay, well, I better do a right portal vein embolization before I operate on this patient. And if it, say, was 10%, you might well say, well, you know what, I actually don't think this patient is fit enough. Yeah. So I had one recently that we recruited into our new trial, because now we're allowed to see the scan results before we operate. And his liver, he'd only had about 3 months of chemo, was bright red, and I'm going, oh, whoa, wait a minute, this will be a disaster. So actually it can work, it can save you doing an unnecessary operation or one that is doomed to a disaster.
It's fascinating that they might be able to determine that from MRI scans, isn't it?
Yeah, so this is groundbreaking stuff, and I was so pleased to be part of it. And I think once it gets released into, you know,
the state of the art. It'll be state of the art.
It'll be state of the art. Yeah.
So you talked earlier on about there are 3 hepatic veins, and is it the inflow or the outflow is critical? both presumably. So for a functional liver, you need portal vein, hepatic artery,
so unlike the rectum, so we need a branch of the artery going in, a branch of the portal vein coming out, a bile duct coming out intact, and a hepatic vein draining it the other way.
So you have to have four structures.
If you have one of those missing, then you've got disaster. So that's why it's so fascinating, really, and that's why I love the liver. It's the seat of the soul, as you know, as the ancients told us. So, do you remember this one, Bill? This slide very early on, because when we first started this journey, Brendan, I used to come home, I had to cry on Bill's shoulder and say, "Bill, they just don't believe me." And do you remember what he used to say? "Merv, it's going to take you 10 years to get your message across."
At least.
And in fact, it's still taking time. Some people still don't believe, So there's still a few non-believers out there, a bit like anti-vaxxers. But anyway, so I'd like to finish, my whole talk in terms of the practice. We can talk about the future perhaps in a minute. But if I have one bee in my bonnet, it's somebody that gets labelled palliative, because that dooms them to never to be discussed by a liver surgeon, perhaps never to be discussed at the MDT or whatever. So this patient, I first came across with a phone call from a mutual friend of ours, the son of a friend, Stevie Tristram. And Stevie, as you know,
was on a boat.
He runs boats in the West Indies as a skipper.
Not off the coast of Wales, so it's too cold.
No, too cold. In the Caribbean. And he rang my secretary one day in the middle of the day in Basingstoke, and my secretary said, "There's a Stevie Tristram on the line." I said, "Stevie? I thought he was in the Caribbean." He said, "Yes, I'm on the boat." He said, "There's a man here who's been told he's got 6 months to live, and he's actually spending it going around the world. So he's with me for a month. But I've learnt that he's got what you do. He's got secondaries in his liver. And I've told him, you should go and see you." I said, "Well, Stevie, it's not that simple." So anyway, I promised to look at the slides. So we got the scans down from his referring hospital. And I think you'll agree, all those black blobs are secondaries, bilateral primary tumour in situ. I mean, that is pretty formidable, and there's nobody who's going to say that is operable. But this is him after 6 months of capecitabine oxaliplatin. The right lobe was atrophied right down. You just see the black blob, and then the left side has really hypertrophied. So I'm going, actually, do you know what? This is really interesting. So I rang Stevie back on his boat and said, "Would you mind dropping him off at the nearest island with an international airport and send him back?" So he came back, bless him, from the Caribbean. I think it was January or February. So we took out segment 3 and then a right apopectomy, and then he went on to have his primary removed in April. You can see the dates there. He even had a lung secondary removed a year later. And here we are, 6 years on, he's alive, free of disease. So, and yet he'd been written off because nobody at a sort of my level had been involved in his care because he was so-called palliative.
It's very interesting, isn't it? We mentioned it briefly, Merv, I think, is that, there is this oligometastatic disease, isn't there? There are patients who seem to get, luckily, a few, and it can include the liver and the lung. And occasionally the peritoneum localized, but if it's carcinomatosis, it's fascinating.
I would say, Brendan, that, Bill, of all the patients who've survived 10 years in our series, they've nearly all had 2 liver operations and at least 1 lung metastasectomy, if not many, or an ablation in the lung.
My next door neighbour. I think the word palliative is a bit of a curse, isn't it?
Well, I think it's a bit unfortunate that one's got to use it very carefully.
One of the aspects that I'm quite interested in is, do you think that chemotherapy ever gets rid of liver metastasis? It must get rid of small metastasis, I suppose, does it?
Okay, so that's an interesting question. So if you go back 10 years, and there were studies showing that if liver metastasis disappeared, that Nollanger, for example, in Paris, produced a paper that 80 to 90% of them could be accounted for and reappeared.
Yeah.
But when you look into the fine detail, that was disappeared on a CT scan. Okay? We fast forward, Sloan Kettering and many others have shown, MD Anderson, that if you disappear on an MRI scan after chemotherapy, there's a good chance that it'll stay disappeared. And the characteristics are that they're usually small lesions, say a centimetre and below. Yeah. And this is the big unknown for us and makes selection so much difficult now, is say you've got 2 big lumps and 8 little ones. And you have your chemotherapy, the 2 big lumps get smaller and the 8 little ones disappear.
What do you do now?
What do you do now? Yeah. Do you, if you're a pessimist, you'd say, well, there's a 50-50 chance they'll come back. The optimist in me say, there's a 50% chance they won't come back. Yeah. So we should operate and try and remove as many of the areas involved, but know that we need to keep a close eye on them, that if they do come back, go after them again.
You may have to re-resect, so that's where you have to be very conservative in preserving.
That's right, never waste the liver.
Yeah.
But doing blind resection doesn't work.
And of course, the problem was that actually a right hepatectomy, it's a difficult operation, but it's much more difficult to do.
Yeah, right hepatectomy is in our book easy.
It's easy.
That's the easy operation. It's a nice straight line, you know.
So I think that chemotherapy undoubtedly can. But of course, we don't have biopsies, all those things. We never talk about biopsy, you know, the liver marrow, but we know that if a lesion is in the liver and you characterize it with MRI scan, you don't have to biopsy it.
You don't need to. And as you know, we published the paper with Oliver Jones, BJS, showing that it's a detrimental thing to that survival of that patient, whether needle tract deposits and so on.
This is something you've been teaching us for years and years and years, but it's still not everywhere respected. Spell it out to them all.
I know, well, yeah, you're right, Bill. I had the slides, I took them out, I shouldn't have done, because we had a case the other day where somebody had laparoscopically just biopsied half a secondary, and I'm going, don't. So we know that if you biopsy tumours in the liver, where the CA has gone up, a scan that was normal now contains 3 lumps, and they are characterized by MRI to be typical of secondaries. They are secondaries. It's like, if you see a horse, it's got a horse's head and 4 legs and a tail that swishes and it's brown. It's a horse. So actually, you don't need to biopsy. And the reason I got to be my bonnet about it, I had 2 young patients who died horrible deaths from needle tract deposits in the chest wall, from where the needle had been in. So, there are other times, occasions where you don't know the diagnosis and you need to know which tumor type to treat with chemotherapy to downsize it, where you actually need the tissue, and that's fair enough. But then we would say, try and biopsy through some liver and embolize the tract so you don't disseminate the cells.
Which we say the same for if you're doing a laparoscopy and you've got peritoneal disease, ideally you want to be in the midline where you can excise the ports principle. We need to talk a little bit about open laparoscopic and robotic, and we need to talk a little bit about transplantation and artificial liver replacement. So perhaps we should come back to that. You can find a whole series of videos and links to our series of discussions around rectal cancer at this address. And if you have any suggestions what we might cover, please let us know. Thank you very much for joining us.